It's time to look at the assessment of the pulmonary system of the patient in the ICU. There will be 4 tutorials in this sequence. This first tutorial will look at assessing oxygenation, the second on assessing ventilation, the third looking at assessing mechanical ventilation, invasive and non-invasive, and then finally we will look at chest imaging. An introduction to critical care, presented by me, your host, Pat Nelligan. Interpreting and integrating the critically ill patient's data. Part 2, Pulmonary. When you are assessing the critically ill patient, you will notice that the majority of them are attached to an oxygen delivery device. It may be a face mask, high-flow nasal cannula, or an endotracheal tube. Any amount of supplemental oxygen is an intervention, and you will want to know why the patient is receiving oxygen, why they are being treated with that device, and you will need to have a system for measuring the impact of oxygen therapy. So in this tutorial, I will discuss assessing the need for oxygen therapy, assessing hypoxemia using the blood gas, assessing hypoxemia using pulse oximetry, and assessing oxygen therapy. When we talk about respiratory failure, the term is really describing one of 3 processes that can occur simultaneously. The first is failure to oxygenate, characterized by reduced partial pressure of oxygen in the blood or reduced oxyhemoglobin saturation. The second is failure to ventilate, and that's characterized by a raised partial pressure of carbon dioxide in the blood. The third is failure to protect the airway, characterized by airway obstruction. This is most commonly seen in coma or fall in the level of consciousness. In this tutorial, we're going to assess oxygenation, and it's important that we actually understand the terms. Hypoxia refers to inadequate oxygen delivery to tissues to fulfill metabolic need. It's impossible to quantify unless it's too late. Anoxia refers to tissue damage, usually the brain, consequent of hypoxia. And hypoxemia refers to a PaO2, that's the partial pressure of oxygen in the blood, number below which we believe that patients are in danger of hypoxia and then anoxia. Traditionally, that number is around 60 millimeters of mercury or 8 kilopascals. But be aware that that number reflects only the dissolved oxygen in the plasma, not the oxygen content of blood, that it relates very strongly to the hemoglobin concentration. Now, a variety of different lung abnormalities result in hypoxemia. These include problems with the airways, problems with the alveoli, problems with the interstitium, extrapulmonary problems, and vascular problems. And I usually use the 6S approach to describe these. You can look at the 6 S's as being the type of material that causes problems in different locations around the lungs. For example, with the airway, it's snotty and slimy material. This is mucus, blood, and other secretions. In the interstitium, we have soggy for water and stiff for pulmonary fibrosis. In the alveoli, we have sticky. This is an inflammatory exudate. In the extrapulmonary area, we have squished. The lungs are being compressed, for example, by a distended bowel patient with abdominal compartment syndrome. And a vascular problem is shunty, a right to left intracardiac shunt. So snotty, slimy, soggy, stiff, sticky, squished, shunty. Run through those in your head every time you see a hypoxia patient and you won't go wrong. The international standard approach for assessing the relationship between oxygen therapy and arterial oxygenation is to use the PaO2 to FiO2 ratio. The PaO2 is the partial pressure of oxygen in arterial blood. The FiO2 is the fraction or percentage of inspired gas that is oxygen. This varies from atmospheric oxygen, 21%, up to 100%, which is the maximum therapeutic oxygen you can give at normal atmospheric pressure. It does not represent the inspired oxygen pressure, and that is problematic as the system does not account for altitude nor hyperbaric oxygen therapy. Gas pressures can be measured in kilopascals or millimeters of mercury. 100 kilopascals is equal to 760 millimeters of mercury, and normal FiO2 is 21%. That represents 21 kilopascals or 160 millimeters of mercury at sea level. As oxygen passes down the concentration gradient from the mouth to the lungs, oxygen dissolves in blood proportionately to the partial pressure. That's Henry's law. Arterial blood can be easily sampled and oxygen tension measured. The magnitude of the difference between the FiO2 and the PaO2 is a good indicator of the severity of lung disease. So the gold standard for assessment of oxygenation in the blood is to check an arterial blood gas. This is performed typically several times a day. So let's put this together. In general, when we give oxygen therapy to our patients, we know the inspired oxygen tension, the FiO2. That is 21% if supplemental oxygen is not being delivered. The degree of hypoxemia is estimated by sampling arterial blood, usually from the radial artery, and analysing it using a blood gas machine. The normal PaO2 is 13 kilopascals or 100 millimeters of mercury. Now that we have two measurements, if we divide the arterial oxygen tension by the FiO2, we obtain the PaO2 to FiO2 ratio. This is so useful as it easily allows us to quantify hypoxemia. Traditionally, the PaO2-FiO2 ratio is reported in millimeters of mercury. To convert it from kilopascals to millimeters of mercury, multiply kilopascals by 7.5. The normal PF ratio is 100 divided by 0.21 or 475. If the patient is receiving 40% oxygen, the FiO2 is 0.4 and has a PaO2 of 80 millimeters of mercury, the calculation is 80 divided by 0.4 equals 200. The lower the numerator, that's the PaO2, or the higher the denominator, the FiO2, the worse the lung injury. Now, assuming that we want to keep our PaO2 at around 100 millimeters of mercury or 12 to 13 kilopascals. And if the lungs are normal, the PF ratio was 475. With progressive increases in the inspired oxygen tension to achieve this goal, the PF ratio falls progressively. The lower the number, the worse the lung injury. A PF ratio of greater than 300 is generally ignored. Between 200 and 300 is considered mild hypoxemia. 100 to 200, which is a much broader range than it really should be, is considered moderate hypoxemia, and lower than 100 is considered severe hypoxemia. Now, you might wonder about the scienciness of this. You're actually dividing a percentage by a number, that is pressure in millimeters of mercury, and you wonder if there is a better alternative way. But nonetheless, this has caught on, and for 30 years or so, it has been the standard way of calculating hypoxemia in acute respiratory distress syndrome. The current definition, the Berlin definition, is acute onset of hypoxemia that's not been caused by fluid overload, where the patient is requiring CPAP of more than 5 centimeters of water, or PEEP of 5 centimeters of water, and the PF ratio is less than 200. What do you do if the PF ratio is falling? Hypoxemia is typically caused by loss of lung volumes. So you look for rapidly reversible elements, such as diuretics or antibiotics or a recruitment maneuver. For example, in the recovery room, if someone's a little bit hypoxemic, we ask them to take a deep breath in, and that pops open a lot of atelectatic lung units. But that doesn't really work in acute lung disease. So you recruit the lungs, you sit the patient erect, you might ask the patient to turn themselves prone. Self-proning became a standard therapy during the COVID-19 pandemic. You can open up the lungs with positive pressure, for example, the use of continuous positive airway pressure, or you can reduce the intra-abdominal pressure if it's compressing the lungs. And you can do this by decompressing the bowel, by stopping enteral feeds, by giving laxatives, by using a bowel management system, etc. Of course, another cause of intra-abdominal hypertension is ascites, and a paracentesis may be performed. Depending on where you live or work in the world, you might have to calculate the PF ratio in kilopascals rather than millimeters of mercury, so I'm just going to cover this now. Normally, the PaO2-FiO2 ratio in kilopascals is 62. In reality, that represents 62% of inspired oxygen gets to arterial blood, because inspired oxygen, if you think about it in kilopascals, is 21 kilopascals. For mild hypoxemia, the PF ratio in kilopascals is 26 to 40, representing the equivalent of 200 to 300 millimeters of mercury. Moderate hypoxemia is 13 to 26, representing 100 to 200 millimeters of mercury, and severe hypoxemia is below 13. So you can see, even though the numbers are different and they're not as nice and roundy in kilopascals versus millimeters of mercury, in either situation, the lower the PF ratio in millimeters of mercury or kilopascals, the greater the oxygenation problem and the more therapy the patient will require to return the PaO2 to a safe level. Let's look at an example of this. As you can see, the lung units that I have placed on this particular picture are quite diseased. The FiO2 is 80% or 0.8, and the PaO2 is 100 millimeters of mercury or 13 kilopascals. We'll do our calculation. The PaO2 divided by the FiO2 is 100 divided by 0.8, and that works out at 125 or 16 in kilopascals. And this is severe hypoxemia that is consistent with ARDS. What do you do when you have a patient who is either getting oxygen therapy or you're concerned that they're hypoxemic and no arterial blood gas is available? Realistically, we only check blood gases every 4 to 6 hours, and so the way we normally monitor oxygenation continuously is to use this device. It's known as a pulse oximeter. It's one of the greatest inventions in the history of medicine. It gives us multiple pieces of information: the presence of a pulse, a heart rate, an indicator of peripheral perfusion, and most importantly, a measurement of oxyhemoglobin saturation. This, in many ways, is a better way of measuring oxygen content of blood. So what is the SaO2, the oxygen saturation of hemoglobin? To understand pulse oximetry, you will need to understand the SaO2. Oxygen, as you're aware, is a gas, and like all gases, it moves from high concentration to lower concentration, a process known as diffusion. So oxygen diffuses from a location in which it's in higher concentration, the alveolus, to the relatively lower concentration of pulmonary arterial blood. When oxygen arrives on the other side of the air-liquid interface, there is a problem. Oxygen does not readily dissolve in blood, or any other liquid for that matter. The amount of oxygen dissolved can be figured out by measuring the partial pressure of oxygen, the PaO2, and multiplying it by its solubility. If you do that, the quantity is vanishingly small. Consequently, our ancestors evolved a transport protein that picks up oxygen in the lungs and releases it to the tissues, and this is known as hemoglobin. The percentage of hemoglobin that is saturated with oxygen is proportional to the partial pressure of oxygen in the blood. The oxygen content of 100 ml of blood is 1.34 times the hemoglobin times the saturation divided by 100. The normal oxyhemoglobin saturation is greater than 92%, and we target oxygen therapy to keep the saturation above that level. This is the oxyhemoglobin dissociation curve that you will see in all of the textbooks. On the x-axis, that's the horizontal axis, you have the partial pressure of oxygen in the blood as measured by the blood gas. On the y-axis, that's the vertical axis, you have the percentage of hemoglobin saturated with oxygen on the blood gas. Note that the curve is S-shaped, reflecting the stronger propensity of hemoglobin to grasp onto oxygen at higher saturation levels. Note that there is an elbow in the curve at approximately 90% saturation, where the oxygen content versus hemoglobin saturation falls dramatically. Hemoglobin is made of protein, and it is the major intracellular component of erythrocytes, red blood cells. It also contains oxygen-binding iron molecules. At baseline, hemoglobin absorbs infrared light and it's colored blue. As oxygen binds to hemoglobin, The strength of the bind becomes progressively stronger as each hemoglobin molecule binds 4 oxygen molecules. The binding of the fourth is stronger than the binding of the first. As hemoglobin becomes oxygenated, or oxyhemoglobin, it absorbs more and more red light, and consequently arterial blood, usually more than 90% saturated, is bright red, and venous blood, approximately 70% saturated, is dark red and purplish. This graph demonstrates the difference in the PaO2 between 100% saturation, 70% saturation, and 50% saturation. And you can see there is a non-linear relationship between the PaO2 and the saturation. And this is the inflection point at 92%. Pulse oximeters measure the SpO2. The basic principles of pulse oximetry are based on differential light absorption along the red to infrared spectrum by pulsatile blood. Oxygenated blood appears red because it absorbs light at 660 nanometers. Deoxygenated blood is blue because it absorbs and reflects light at 940 nanometers. That's infrared. The oximeter has 2 light-emitting diodes at 660 nanometers and 940 nanometers, and it filters out non-pulsatile tissues. Consequently, the device is able to numerically identify both the saturation of hemoglobin with oxygen and the heart rate. Indeed, the area under the curve of the pulse waveform could theoretically be used to calculate stroke volume. However, arterial cannulae are superior in the performance of this. You can see the red light on the inside that goes through the finger and the receiver for light on the other side. Here's the finger going into the oximeter, and notice how bright that light is. And it's on, and now we have a pulse. And this is the characteristic pulse trace and saturation that you see. The pulse trace gives you information about heart rate, rhythm, and to an extent, cardiac output. Although they're measured in different ways, the SpO2 correlates pretty well with the SaO2 in the blood gas. Pulse oximetry is affected by low pulsatile blood volumes such as shock states, tourniquets, interference, etc. And it can drive you nuts in the operating room because the number jumps up and down and it's interfered with by diathermy. The other major problem with the SpO2 is the time lag. Every anesthesiologist will tell you that they can see a patient going cyanotic a full 30 seconds before the saturation drops. This results in an intervention, and invariably someone else in the room starts doing an inevitable decremental countdown just as the patient is pinking up. So keep that time lag in mind when you're using standard oximeters. Regardless, it's important to remember the non-linearity of the number. 80% does not correlate with 10% lower than 90%, etc. Sometimes also the saturation and the PaO2 are discorrelating. When I'm in the ICU, I look carefully at the blood gas, keeping in mind that we want the PaO2 at 8 kilopascals or 60 millimeters of mercury or more, and we look to see if the SaO2 correlates with this. If it's 88% when the PaO2 is 60 millimeters of mercury, that's fine. Sometimes it's 93%, and that's our goal. Here is the rule of thumb for our goal SpO2 for otherwise normal lungs. When a patient might have mild ventilation perfusion mismatch due to atelectasis, pulmonary edema, or consolidation, then a saturation of 95% is a reasonable goal. For severe pneumonia or ARDS, 92%, although that might need to be adjusted downwards. For patients with COPD, 88% is where you're looking, and if the patient has chronic fibrotic respiratory failure, then you need to set a reasonable target, to me 80% or more. In those cases, you have to be careful giving oxygen therapy to normalize a saturation or blood gas that is not normal at baseline. Before we get into a discussion about oxygen therapy, it's important that I cover some basic respiratory physiology. Please bear with me for 5 minutes. If you understand what I'm about to tell you, you will find understanding respiratory failure and mechanical ventilation so much easier. You and I breathe in and out all the time. We have this idea that we're either breathing in or breathing out most of the time, but in fact, we're not doing anything. we're neither inspiring or expiring, our lungs are held at a base lung volume. And that lung volume is based on a couple of things. The first thing is the tendency of the chest wall to spring outwards. And secondly, on the tendency of the lungs to collapse inwards. So the chest wall springs outwards, the lungs collapse inwards. And that balance is held by the negative pleural pressure. That's the pressure within the pleural cavity. That volume, that's essentially what we have at end expiration or beginning inspiration, is known as the functional residual capacity. It is the resting state of the lungs. It is about 30 to 35 mils of ideal body weight. It's made up of the expiratory reserve volume and the residual volume, but it's the volume that the lungs hang out at, and that's where most gas exchange occurs, F4C. When are the lungs at functional residual capacity? The way we think about the breathing cycle is that it's binary. You're either in inspiration, which is an active process, or expiration, which is an elastic recoil process. Inspiration is actually quite a short period of time. It's maybe 0.6 to 0.8 seconds. Most of the time is spent in expiration, but most of that expiratory time is after exhalation has finished. Nothing much is going on at all. So most of the minute, if you look at minute ventilation, the lungs are sitting at functional residual capacity, and that's why it's so important. Now let's zoom in on the airways. The most microscopic of the airways involves the alveoli, and the alveoli are little bubbles at the end of terminal bronchioles, and they're surrounded by capillaries, and blood flows through the capillary network into the alveolus, and oxygen goes into the blood, carbon dioxide comes out of the blood, and then the blood goes into the pulmonary vein, left side of the heart, in systemic circulation. And if 1 unit of ventilation equals 1 unit of perfusion, then we call the ventilation to perfusion ratio perfectly matched. It's 1. If, for example, that lung unit completely collapsed and you have atelectasis or consolidation, there's basically no ventilation going into that lung unit, then venous blood shunts through that alveolus and picks up no oxygen along the way. And we call this shunting. So there's 0 units of ventilation and 1 unit of perfusion, and the ventilation to perfusion ratio is 0. Shunting definitely occurs, and it occurs in severe lung injuries or lung injuries with a lot of atelectasis where hypoxic vasoconstriction doesn't work. In this cartoon, I've simplified the lungs into 3 different lung units. The first one, on the extreme left-hand side, is a well-ventilated lung unit, but the blood flow into that lung unit is very poor. This may be because there's too much PEEP present, maybe it's in the anterior apical segments of the lungs, or for some other reason that blood flow is poor. And in this situation, we've lots of ventilation, but not much perfusion. And as a result, there is wasted ventilation, and we call this relative dead space ventilation. Now, this isn't a huge problem most of the time, but it can increase the work of breathing and result in hypercarbia. But we don't get hugely excited about this because it's not usually life-threatening. The other 2 lung units are 2 and 3, and you can see lung unit 2 and 3 are very well perfused. Lung unit 2 has lots of gunk, slime and snot and all kinds of stuff in the airway, and as a result the alveolus is small and the gas inside it is very, very stale looking. Lung unit 3 is kind of similar, but there's a lot of interstitial edema around it. So you have a combination of both stale gas, but also a lot of fluid in the way. And as a result, in both of these lung units, there is good perfusion, but not great ventilation. So the ventilation perfusion ratio is less than 1. And as a consequence of this, the patient develops hypoxemia. And you can see that the saturation of the hemoglobin in the blood going back to the left side of the heart is lower than you would like. The treatment for ventilation perfusion mismatch is oxygen therapy. And we are going to administer 30% oxygen. Although you might think that increasing the FiO2 from 21% to 30% is not much, that's actually a huge increase in the FiO2, with the result that the PiO2 increases up to 228 millimeters of mercury or 38 kilopascals. Let's see what happens as that oxygen works its way down into the airways. Lung Unit 1 was already well aerated. The additional oxygen, although it increases the alveolar oxygen tension, exerts its impact on gas exchange by activating vasodilatory mechanisms locally and increasing blood flow. The result is improved ventilation perfusion matching. In Lung Unit 2, where there is stale gas, the supplemental oxygen drives the alveolar oxygen tension above 100 millimeters of mercury or 13 kilopascals, resulting in the abolition of venous admixture through this unit. Lung Unit 3 is both slimy and soggy and likely in the posterior dorsal segments. Additional oxygen here increases the alveolar oxygen tension, but the persistently low surface area results in a not fully effective ventilation perfusion match, and therefore there is persistent venous admixture. The overall effect of this oxygen therapy is to drive the PaO2 up to 90 millimeters of mercury or 12 kilopascals and improve the saturation above 95%. Of key importance here is that giving the patient any more oxygen than this will be ineffective because it's done what it needed to do. Oxygen therapy is really effective in the treatment of moderate hypoxemia. Oxygen therapy is typically titrated. That is, the inspired oxygen tension is carefully tailored to a specific oxyhemoglobin saturation or PaO2. There is a second component to oxygen therapy, and that is gas flow. Typically, this is adjusted to match patient flow demands and reduce respiratory distress. Titrated or targeted oxygen therapy. The goal of targeted oxygen therapy is to increase alveolar oxygen tension and prevent the gas that lies there from becoming stale. Targeted therapy leads to most alveoli having at least an alveolar oxygen tension of 110 millimeters of mercury or 14 kilopascals or higher, depending on the PaO2-FiO2 ratio. In addition, oxygen is a very potent vasodilator, so it recruits high ventilation to perfusion units, that's relative dead space, and it redistributes blood flow away from low ventilation to perfusion units, so it overall improves ventilation to perfusion matching. So how do we give oxygen therapy? Well, this is a little bit complicated. We have low to medium flow systems, or so-called variable performance devices, like simple face masks and nasal cannulae, and we tend to use these in patients with mild hypoxemia. Alternatively, we do have fixed performance devices such as Venturi masks or partial rebreather masks or non-rebreather face masks that are used in moderate hypoxemia. But if you're in the ICU and you're moderately hypoxemic, you're much more likely to receive a high flow system. And these are flow generator devices that give patients high flow oxygen therapy, usually through the nose, so it's known as high flow nasal oxygen therapy or CPAP, or indeed mechanical ventilation. And that's what we use for moderate to severe hypoxemia. Nasal cannulae tend to be used for up to 6 liters or 44%. Beyond that point, patients will receive high flow oxygen therapy up to 60%. So in general, you won't see simple face masks or Venturi devices in critical care. If patients fail to oxygenate with high flow, they will be given a trial of CPAP, continuous positive airway pressure, up to 10 centimeters of water. But if that fails, the patients need to be intubated and mechanically ventilated. Nasal cannulae are commonly used on wards, and in the hospital I use them all the time myself. These are 2 prongs that go 1 centimeter up into each nostril, and the nasopharynx acts as a reservoir for oxygenation. The patient doesn't need to breathe through their nose, and the patient breathes through their mouth. They suck in air from the room, and it dilutes in all of that oxygen that's in the nasopharynx, and a certain amount of oxygen is delivered to the lungs. And the FiO2 depends on the flow rate, the volume of the nasopharynx, the respiratory rate, and the tidal volume. But as a general rule of thumb, if you're using nasal cannulae, Every additional 1 litre of flow adds 4% above 20%. So 2 litres will give the patient 28% oxygen. And just to show you that in a table form, 1 litre is 24%, 2 litres 28%, 3 litres 32%, 4 litres 36%, 5 litres 40%, 6 litres 44%. Now let's move on to high flow oxygen therapy. There are a couple of systems for delivering high flow oxygen therapy. This is one system using an ICU ventilator. Note the oxygen and air sources. The ventilator blends the air and oxygen as prescribed, and then the dry gas enters the humidifier, from which it emerges through a single patient tube that attaches to the oxygen delivery device, in this case nasal cannulae. The prescription is seen on the top of the screen. The patient is getting a 50% oxygen through a flow of 45 litres per minute. This is the typical way that we use high flow oxygen therapy. The patient is getting 30% oxygen and has a respiratory rate of 36 and is working hard with a saturation of 86%. So we have to set our goals. Saturation between 92 and 94% with a respiratory rate of lower than 25 breaths per minute with reduced work of breathing. We're going to increase the FiO2 to 40% and titrate the flow. So the flow is going to go up to 40 litres and we're going to keep titrating. We increase or decrease the flow rates in 5 litres per minute intervals and increase or decrease the FiO2 in 5% intervals. So the saturation or the blood gas is related to the amount of oxygen we give. The respiratory rate and the apparent work of breathing relates to the flow. If high flow doesn't work, we give the patient CPAP. This is what occurs in normal lungs during inspiration and expiration. The majority of lung units are patent throughout the respiratory cycle, with a slight increase. Remember, this is only 450 mL over a lung volume of 5 litres in inspiration. The purpose of inspiration is to remove CO2 by bulk flow. When lungs become soggy, slimy, stiff, etc., there is loss of volume in expiration. The lungs become less compliant, and because of the lower surface area for gas exchange during expiration, there is ventilation perfusion mismatch and shunting of deoxygenated blood through the lungs and a reduction in arterial oxygen tension. To treat and prevent this, a positive pressure is placed during expiration that prevents the lungs from emptying as much as they normally would by elastic recoil. This is called PEEP, positive end expiratory pressure. But if the same amount of pressure is applied across the respiratory cycle, we call it CPAP, continuous positive airway pressure. CPAP prevents end expiratory lung collapse, increasing the surface area for gas exchange, preventing lung derecruitment. The impact is to improve oxygenation. In some lung units, this will be completely ineffective. In others, it'll be partially effective. But overall, in most patients with moderate lung disease, CPAP is an extremely effective way of improving oxygenation. It applies positive pressure to the airway during the entire respiratory cycle, and we measure CPAP in centimeters of water, usually starting with 5 centimeters of water. Its main purpose is to prevent end expiratory lung derecruitment, improving oxygenation, but it also reduces the work of breathing by overcoming both elastic and resistive work. CPAP is used in a variety of scenarios, principally in the community for obstructive sleep apnea. It's used in recovery rooms and in post-operative care units to treat post-operative atelectasis. It's used to treat moderate hypoxemia in pneumonia, and it's also used to treat heart failure and pulmonary edema. There are different types of delivery devices for CPAP, but usually these days we give CPAP through a non-invasive ventilator, such as the one that's on the left-hand side of the screen. In the community, the most common way CPAP is delivered is through a nasal CPAP mask, but this is rarely used in the ICU. We usually use a mask that either covers the mouth and the nose or covers the entire face. In some circumstances, for patients who have pretty bad hypoxemia who you don't want to intubate, this is something we did quite a lot during the COVID-19 pandemic. We use a helmet that covers the entire head. This is actually more comfortable than you might imagine. In terms of the sequence of interventions for managing the hypoxic patient, the first thing that you must do is sit the patient up. The erect position improves functional residual capacity, that is the resting lung volume, considerably, particularly if there is pressure-related atelectasis, for example, of the left lower lobe bronchus. We will then give oxygen therapy, starting with nasal cannulae with oxygen up to 6 litres. Oxygen can also be delivered by simple face masks. Now, instead of using Venturi devices these days, we tend to use high-flow nasal oxygen because of the precision in the amount of oxygen that we give, and also the reduced work of breathing and improved CO2 clearance associated with high flow. If this is not sufficient to get the patient to a saturation that is satisfactory, we are going to go ahead and give the patient continuous positive airway pressure through a non-invasive ventilator, starting with 5 centimeters of water, then escalating to 7.5, and then to 10 centimeters of water. If this is ineffective or the patient is struggling, we will go ahead and intubate the patient and increase their mean airway pressure by combining PEEP with positive pressure ventilation. So overall, when we're assessing oxygenation, by far the most important piece of information that we need from the blood gas is the PaO2-FiO2 ratio. Anything below 200 is not good. Then we're going to look at our oxygen delivery device. These are nasal cannula, face masks, high flow, CPAP masks, and CPAP helmets. If you're using high flow, you need to know the flow rate. If you're using CPAP, you need to know the CPAP level. One last thing. If you happen to see this device at a patient's bedside, that is not good. This is the delivery system for inhaled nitric oxide, a direct-acting vasodilator. The gas is administered through the breathing apparatus and it reduces pulmonary arterial pressures, improving overall blood flow and oxygenation. It is sometimes administered following cardiac surgery when the right ventricle is dysfunctional or in severe ARDS as a rescue therapy. Inhaled nitric oxide is delivered in parts per million. The higher the number, the worse the situation is. Let's review this tutorial. This tutorial looked at monitoring of oxygenation and assessing oxygenation in the critically ill patient. I started with a discussion about the essential method that we use of comparing oxygenation from patient to patient from time to time, and that is to calculate the PaO2 to FiO2 ratio. This is a component of the definition of acute respiratory distress syndrome. I then moved on to talk about pulse oximeters, how they work, saturation targets, and then I looked at the different oxygen delivery devices. In the next tutorial, I'm going to discuss the monitoring of ventilation in the critically ill patient. When I talk about ventilation, we're talking about carbon dioxide. And we will look at the combination of the pH, the PaCO2 and the bicarbonate, and how alterations between the three of these helps us understand what is going on with the patient's respiratory apparatus. I'll then talk about measurement of airway gases, principally end-tidal CO2 and capnography. I'll see you then, and I guarantee you'll learn something. So that was my tutorial on assessing oxygenation. I have loads more material on this on my YouTube channel and on my blog. And don't forget to subscribe if you're enjoying these tutorials and leave me comments and likes.